All right. Hello, everybody. Today we will be talking about transport operations. So without further ado, let's get into it. Okay, so ambulances. Ambulances today, there's kind of a wide variety, and we'll talk more about what they are here in this lecture, but today's ambulances are stocked with standard medical supplies. Many are equipped with state-of-the-art technology that can transmit data directly to the emergency department as well. And then today's emphasis on rapid response places EMT in greater danger. The faster you're moving, especially in a vehicle, the higher likelihood of incidents occurring. And this is something that does come up. So we'll talk about ambulance safety and things to look out for just for your overall well-being as a provider out in the field. Okay, so emergency vehicle design. An ambulance, a vehicle that is used for treating and transporting patients who need emergency medical care to a hospital. Today's ambulances designs are based on NFPA 1917 standard for automotive ambulances and suggestions from the industry. So it's an ever-evolving thing, and we're constantly, this field rather, is constantly evolving to keep the latest and greatest out there so that we have the best potential options for our patients so that both us providers and our patients are arriving to the hospital safely. So some components, we have our driver's compartment, otherwise known as the cab, right? So usually a driver in a passenger seat. In the back, we'll have a patient compartment big enough for 2 EMTs, as well as 2 supine patients. Now, in reality, most ambulances would try to max at 1 supine patient with the gurney, but I'm assuming with this 2 supine patients, that leaves the opportunity for the utilization of a bench seat, which is typically standard next to the gurney. It'll have equipment and supplies, 2-way radio communication, and is designed for maximum safety, efficiency, and comfort. Okay, and depending on the system you work in, you may be in a system that works system status, where you go and park on a corner and basically run your calls, and that's kind of your district. Some systems, like the one I was working with, you will have stations. So it really just depends on where you're at as well, but definitely comfort for the provider is a big one. Okay, now there are 3 types, okay, and I don't typically stop on these tables, but I will for this one. So type 1, conventional truck cab chassis with modular ambulance body that can be transferred to a newer chassis as needed. The second one, type 2, standard van, forward control integral cab body ambulance. The van ambulance, if you will. And then type 3, specialty van cab with a modular ambulance body that can be mounted on a cutaway van chassis. So we'll show you pictures here in a moment. Each one of these, regardless, is going to have the Star of Life, right? The traditional EMS kind of logo, for lack of a better term. But ambulance licensing or certification standards are established by the states, so individual states can have preferences on what they want in their vehicles. And then the Star of Life emblem is affixed to the sides, rear, and roof of the ambulance just as a notifier, right? Making sure everyone knows this is an ambulance. That's why a lot of times if people buy out-of-service ambulances, they have to strip the Star of Life off. And here's our images here. So truck chassis, and then we have our standard vanbulance, and then there's the van with that mounted chassis on there as well, or with that mounted box on the chassis rather. Okay, so phases of an ambulance call. We will work through each one of these individually. We'll just kind of touch on them now, but prep for the call, dispatch, en route, right? So we're going towards wherever the call is occurring. Arrival at scene, from there transfer the patient to the ambulance, en route to the hospital. At the receiving facility, we're going to drop the patient off, and then en route to the station, as well as post-run. Post-run being after the call, you've gotten back to your station or wherever you're staging so that you can kind of get ahead of the next steps before the next call hits you. So the prep phase, make sure your equipment and supplies are in proper places and ready to use. Okay, so store new equipment only after proper instruction on its use and consulting with the medical director, and equipment should be durable and standardized. So the beginning of my day when I was on the ambulance literally would start with what's the crew, or how was the crew doing from the last call, or the last shift, how were their calls, do they have any overnight, are we missing anything? From there I would go straight into my ambulance and I would start to inventory everything, touch everything, know where it is, because if you don't know where it is, and you have something critical where you're going to need a certain piece of equipment, the last thing we want you doing is fumbling around trying to find something when you should already know where it is, okay? Also, the last thing you want is to not have something when you really need it. So make sure you know. Now, as far as storage, store the equipment and supplies according to how urgently and how often they're used, and we'll give you kind of a layout for what that looks like. But items for life-threatening conditions are typically at the head of the stretcher or the primary stretcher. Okay, that's going to be more like airway management type stuff. Items for cardiac care, external bleeding, and blood pressure will be on the side of the stretcher. That way we can reach and grab it quickly. It's readily available so we can access it. Now, most ambulances, can't speak to all of them, but most ambulances will have cabinets, drawers that will be labeled. And if they're not labeled, the individual items will be labeled as to where they should go. But if you kind of follow the backtracking here, if you kind of keep this in mind, right? Life-saving stuff is going to be life-threatening stuff's at the head, and then most of the external stuff, blood pressure, so on and so forth, will be at the side so we can grab that fairly quickly. And that's typically going to be those cabinets. Now, as far as equipment is concerned, basic supplies, airway ventilation equipment, CPR equipment, and basic wound care, right? Your standard, what are the potentials we could run into today on whatever calls we have. We want to make sure we have the essential stuff to make sure that we are going to be successful and give our patient a good outcome. Now, splinting supplies, childbirth supplies, AEDs, right? That's going to be a continuation. So you just never know, right? That's kind of the point of this field. A lot of people get into this field because it's, quote, something different every day, which isn't always the truest statement. It tends to be one of like 15 categories, just different circumstances, but we still want to be prepared for whatever that call type will be, depending on when it pops up. We need to have equipment to transfer, patient transfer equipment. We need meds, we need jump kits. Now, jump kit, I'll come back to patient transfer equipment. The jump kit has a lot of different names. Your go bag, your first in bag, your jump kit. That's what do you bring in for the majority of your calls, right? What is the one piece of or bag of equipment that you want that's going to kind of be your catch-all for maybe something that's of a lower critical point or lower acuity. And as far as patient transfer equipment goes, right, gurney is going to be the obvious, or the stretcher, the most obvious one. There are going to be things like mega movers, right? So like kind of tarps with handles that we can move to get patients ready, or pediatric, the PD mate is an example that we carried at the department I was with. Something that we can put a child on and transport them safely without endangering them on the roads, right? Kind of an additional set of seat belts. So you just never really know, right? But depending on your agency, depending on your department, be familiar with what you will need to start moving patients around. We'll have our own safety equipment, right? As well as equipment for work areas, but our own safety equipment being a big one as far as like high-vis vests, right? High visibility vests or hats or whatever need to be on the ambulance to some degree, because obviously we operate in all times of year, all time of day. So you just never really know what you're going to need once again. Okay, but having it around and available is the perfect thing, because you might not need it for one call, but you certainly will for the next. Okay. Usually up in the cab, you'll have some sort of pre-planning and navigation equipment. Depending on the agency you work for, the agency I worked at had a CAD system, so we would see the call come up. It would give us a location to where to go. We could even map ourselves there using the CAD. We also had a GPS unit that we could just plug in addresses if we didn't want to use the CAD on the laptop, which was ideal for me personally, mostly because if I was going to be rider as a passenger, right? I'm getting ready for the call. If it's likely going to be an ALS call at the medic scope, the EMT would be driving at that point. I would plug the address into the GPS unit so that I could just check the live updates on what our call is going to be. You'll also have a slew of extrication equipment depending on your location, depending on, as far as, you know, in the country, as well as depending on what type of apparatus you're on. For example, fire engines, right, are going to have a different set of extrication equipment compared to an ambulance. Now, as far as personnel, at least one EMT in the patient compartment during transport, right? That's the whole point. Can we get a provider in the back to provide care to the patient that is in need? So at least one EMT will need to be in the back, depending on your system, depending on how it works, right? For the system I worked in, we were almost always, or rephrasing, we had a medic on every single ambulance. It just wasn't always dual medic. Sometimes it was a medic and an EMT, sometimes it was a medic and advanced EMT, but that differs all around the country. So make sure you're paying attention to your local stuff there. Now, 2 EMTs are strongly recommended as far as on the ambulance. So one will drive, one will take the call, and then oftentimes it's a swap, right? So I take this call, that means the next call is yours, I'll take the next, so on and so forth, okay? Now, depending on where you work, once again, some services will have a non-EMT driver and just a single EMT in the compartment. Usually more rural areas for my information, but or per what I've heard anyway, but not uncommon, right? There are just people who drive the ambulance, not just the EMTs the whole time. So I kind of talked about it, right? Daily inspection. So the first thing we got to do is check everything in the ambulance. What's our gas look like? Is there anything that needs servicing on the vehicle itself? Is my equipment all present? Am I missing anything? If so, I need to replace that. From there, I'm going to make sure everything's clean, right? And that includes the ambulance. Wash your ambulance every single day. Keep it clean, okay? But inside, is there blood from a previous call up on a handle or on the side of the gurney? Let's clean it all up, okay? What's the quantity of our equipment? And then some equipment will be reused, right? So for example, ventilators. Does your vent work? Does your oxygen tank work? Okay. If you have a pump, is that pump up to standard? Is it going to work if we need it to? Make sure you're testing this equipment before you get out onto the road, because once again, the last thing we want is to show up to a situation and not have what we need, or what we have is not up to snuff. It's not going to do the job. Check your suction unit as well, right? As another example. So review your safety precautions. So review traffic safety rules and regulations. That's pretty burned in. Once you get out into the field, your agency will have a set protocol and safety guideline that you will be expected to follow. That is the standard to make sure that everyone is going to be going home, right? Making sure everyone's safe while in this vehicle. Ensure safety devices are in working order, and then properly secure your oxygen tanks. Always, 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 oxygen tanks should be on their side, mounted to something. If they're going to be vertical, once again, mounted so they will not be tipping over. It's going to be a huge deal. And then properly secure all equipment in the cab, rear, and compartments. At the agency I worked for, we used to keep our first in bag, our jump bag, go bag, whatever you want to call it. We would keep that on the gurney with our monitor, and then from there we would actually strap that down to the gurney using the gurney seat belts so that nothing would go flying around should the worst case scenario happen, because it has happened and it could happen again. So make sure you are just ensuring your own safety. Okay, so moving into the dispatch phase, right? You are spending your time doing whatever, your system status. If you're going to be in a station, you're just hanging out doing your thing, right? From there, dispatch, right? So dispatch will reach out to you. Dispatch must be easy to access, service 24 hours a day. There are dispatching centers for that exact reason. Now, depending on where you work, where you live, may be operated by local EMS or by a shared service. Here locally, we have a shared service through the Sheriff's Department as well. Now, it may serve only one jurisdiction or maybe on an area or a regional center. It just depends. There's so many what ifs because different areas of the country function very differently in EMS. Now, dispatchers should gather and record nature of the call, right? So someone on the phone, 911 happens, an emergency happens, they call 911, they reach a dispatcher. Dispatcher will find out what is the nature of the call. That'll help them decide, do we need EMS, fire, police, all of the above, some sort of combination of the like, okay? From there, we'll get a name, their present location, and a potential callback number. Location of the patient, once again. They'll also tell us the number of patients, and it says severity of their conditions. I'll come back to that, but there's some key things to keep in mind. And then other pertinent information. Doors are locked, the garage code is X, there's a dog, right? Whatever that is. Dispatch will try and gather as much as they can. Now, the severity of their condition. Remember, dispatchers are just people on phones, not to downplay what they do by any means. Respect your dispatchers, but they're people on the phone. If someone's having an anxiety panic attack and they're huffing and puffing and breathing hard and having a hard time getting words out, well, if I'm on the phone, that could sound like shortness of breath, okay? So don't be surprised if the nature of the call is similar to the dispatch notes, but not quite there, okay? It could be a little different. Just take it with a grain of salt. These people are doing their absolute best to give us the best information they can. Once again, they are limited to a phone call, okay? There's only so much they can do and gather for us. Now, From there, we've been dispatched. You are dispatched to whatever, X, okay? We need to get en route. Now, this is the most dangerous portion throughout the call, is going en route to a call, because more often than not, we're going lights and sirens. We're trying to get there quickly, right? We are breaking traffic laws legally using our apparatus. That said, ambulance accidents do happen, right? So crashes cause many serious injuries. So fasten your seatbelts, your shoulder harnesses before moving the ambulance. Okay, and then part of that, review your dispatch information. What are we going to? What do I need to be prepared to deal with? And then prepare to assess and care for the patient. But yeah, crashes do happen. Wear your seatbelts. I myself was in an ambulance wreck 2019. I was in the back. We ended up, we were cutting through a freeway barrier at an emergency vehicle point. People weren't paying attention. Someone about a few cars back from us was watching the wreck that we were trying to go to, looked up, saw tail lights swerved into the shoulder, and that just happened to be where we were. Fortunately, I was wearing my seatbelt in the back. However, that monitor that I was talking about was not strapped in at the time. The protocol and policy changed immediately after that. But I watched that monitor come fly in my direction as we got hit, okay? So keep that in mind. Wear your seatbelt, strap your stuff down, because especially if you have more than 2 people in that ambulance, a third provider potentially, they're in the back. So anything that happens in the back, things are gonna go flying around. Protect each other, protect yourselves. Do yourself the due diligence. Now, when we arrive at scene, this should not be news, right? BSI, scene save, PPE. But perform a scene size up and report your findings to dispatch. Is there anything that's a safety hazard? There's downed electrical lines, there's ice on the road, whatever, okay? Do we need additional units? Is this something where, oh, it's a hazmat situation, or we need a dive team, or this person's really heavy, we need help picking them up? Determine your mechanism of injury or nature of illness. Is this trauma? Is this medical? Which one do we need to start diving into? Okay, can we start putting pieces together? As we show up to a car wreck, who hit who? Can we start to put those puzzle pieces together? Evaluate the need for spinal immobilization, and then follow your standard precautions. Once again, standard precautions, gloves, PPE, wear your goggles, wear your gloves, keep a mask on you because you never know. If we're dealing with a mass casualty incident, so we have more than one patient that we are concerned for, okay, estimate and communicate the number of patients to the incident commander. Hey, I'm noticing there's 2 green patients, 2 yellow patients, and a red. Okay, they need to divvy that out because there's an order of importance about who needs to go first. We can request additional units through dispatch, and then the incident command system will be established, right? This is where the ICS stuff starts to show up. Parking. Parking is a bigger deal than you'd think. First of all, allow efficient traffic flow and control around an emergency scene, right? We want to make sure that people can still go about their day-to-day lives as best they can, obviously barring car wrecks eating up a whole intersection or whatever. But yeah, we should try and be present and noticeable, but not in the way, if we can get away with it. Park 100 feet before past the crash scene. I'll come back to that. Do not park alongside a crash scene. Park uphill, upwind of hazardous materials. Make sure if we have some sort of hazmat, there's a downed tank of something gaseous, right? That we are upwind of that. That way it's not just blowing it towards us into the ambulance where we're gonna have patients. Leave your lights on, right? We want the lights on. We don't need the sirens necessarily if we're just outside, right? But keep the lights on so we're visible. And then keep a safe distance between the emergency vehicle and operations. Now we'll talk about it, but where we park is a big deal, okay? And this depends on the apparatus you're dealing with. So the car in the middle of this diagram obviously was the car in the collision. If we're talking traffic is flowing this way, first and foremost, if we're the ambulance and we show up first, we want to park down the road from the wreck. Reason being, hopefully we have the patient in the ambulance at that point. If someone's not paying attention and they do hit us, right, the likelihood of them hitting the crashed car with no one in it before they hit us with our patient is higher if we park down the road, okay? If you're a fire engine, they will park in front of the vehicle. They are a larger, the crash vehicle, but they're a larger piece of apparatus, the big bright lights. People see fire engines, okay? Use them to block the whole scene. That way, worst case scenario, someone does hit the fire engine. 1, big, heavy, likely not gonna move a lot. But 2, even if it does, they hit the fire engine, they hit the crash car before they hit the ambulance that potentially has patients and providers in it. And if we can, use flares, cones, right? Notify if you're going to do a flare, maybe go 100 feet down the road, make sure people are aware that there's some sort of incident occurring up here. We need to make sure that everybody is paying attention, sees us for the obvious reasons. So if there's going to be a fire, stay away from fires, explosive hazards, downed wires, unstable structures, right? We want to make sure that we are setting ourselves up for success so that there's no sort of potential sideways issue that could show up, okay? Set your parking brake. That's a pretty big one. Try not to, establish the parking brake. That way when you're stopped, you're ready to go. Or you know what I mean. Okay, so facilitate emergency medical care, rapid transport from the scene. If it's necessary to block traffic, work quickly and safely. Remember, we can also contact law enforcement. They can get involved and they can clear or block an intersection for us as need be. For traffic control, provide care and ensure scene safety first. We have to look out for ourselves and our patient first and foremost, but we want to make sure also bystanders are not going to be involved, right? Because if people start crashing their cars in front of a wreck, then we got more patients, more problems. Traffic control is intended to ensure orderly traffic flow, warn other drivers, and prevent another crash, kind of like I was talking about there. And then place warning devices on both sides of the crash. Okay, so that's going to be whether it's flares, cones, lights, and then even our apparatus could fall under that. Now, we have our patient. We got to get them to the hospital. We need to transfer them. So this is the packaging portion of that. Okay, so patient must be packaged for transport. So secure the patient to a backboard, scoop stretcher, or wheeled ambulance stretcher, whatever your protocols prefer you to do. More often than not, we would just try to get them onto the stretcher itself. If it was going to be something like a scoop stretcher, I would put them on there and then remove the scoop, obviously time permitting and situation permitting. Lift the patient into the compartment, secure the patient with straps. Now, if you're curious about what type of apparatus is out there for lifting and moving these patients, you can check out our lifting and moving lecture. We also, nowadays, a lot of ambulances, to avoid potential provider injury to their back, use automated gurneys. So it's not lifting it up into the back like you see in the movies. It's pushing a button, the legs will rise, and we can push it in. But we have them packaged, we're ready to go. So let's transport, the transport phase. So when you are ready to leave with the patient, inform dispatch. How many patients do we have? Currently en route with one patient. We are going to which hospital? So receiving facility. And then what is the beginning mileage of the ambulance? We want to know how far we were going from the crash site or injury site or call site or however you want to phrase that to the hospital. That way we know if your system is one that bills for distance traveled, they can keep that aware. Now, a lot of this can be wrapped up as well into a CAD system. At the system I worked at, we would, when we get on scene, we would hit, well, first we get dispatch, we would hit en route on the CAD system. When we got to the scene, we would say on scene. When we were going to be leaving, we would hit en route to hospital, and that would force us to select which hospital in our local area we were going to. And then from there, you transport. When you'd get to the hospital, right, and you're still clearing your mileage. When we get to the hospital, I would hit at destination, and it would say, what was your distance? At that point, I would do the math. We went X amount of miles. Or if you just clear it out, right, you know exactly how far you went. So monitor the patient's condition en route, right, as a provider. Stable patients, we recheck every 15 minutes. Non-stable or unstable patients, we will check every 5 minutes. While you're en route, also make sure you tell the hospital what you're bringing in. We don't need names or anything specific. A short, sweet, concise radio report. We are coming to your facility with a 40-year-old male, chief complaint of chest pain. At this time, patient has been giving X. Last set of vitals is X. We'll see you in 10 minutes. Do you have any questions, right? Quick, easy, concise. Let them know because they want to be prepped too. The last thing you want to do is show up to a hospital who doesn't know you're coming, and then you're gonna get yelled at by some doctors. Maybe not doctors, but hospital staff, okay? Do not abandon the patient emotionally. That's a big thing, right? Keep them in the loop with their own care. Be there for them. Half the time our calls are more so that we can be a patient advocate, and some people just need a hand to hold or a shoulder to cry on. Okay, so don't just neglect the patient because you're so focused in on what you need to do on your end of things. Remember, the only reason we're here is because of that person. Okay, so do your best to keep them included and don't just leave them high and dry on an emotional island of sorts. And then be aware of the patient's level of need. Obviously, that'll differ depending on the call. All right, so we are transported. We have arrived at the hospital. So notify dispatch of your arrival at the hospital. Dispatch, medic, whatever, is at whatever hospital, okay? Report your arrival to the triage nurse or other arrival personnel. More often than not, you walk in and some sort of registration person will meet you, tell you which room we're going to. And from there, we'll physically transfer the patient. Once we have the patient, on the gurney, on the hospital bed from the gurney, we'll give a verbal report to the nurse or the doctor or whatever presenting medical staff is there. Remember, at an equal or higher level of care. That way we are avoiding negligence, okay? And this is also, the verbal report is also when we can start to give more details. So 45-year-old male chest pain via the radio report. Yeah, so we show up, we find 45-year-old male sitting in his recliner. He seemed uncomfortable, noted diaphoresis, low blood pressure, pale skin, right? We can give them more of the nitty gritty. The radio report needs to be short, sweet, concise. The verbal report is going to be something we can go into context. Let's have more of a conversation about what happened, depending on the severity. Sometimes you just got to holler to a room because the patient's in a bad way. Okay, so complete your detailed patient care report. Restock items if possible, depending on where you work, right? Some places may restock out of a hospital, others will have their own stocking stations. You will have to put 2 and 2 together. If you need something desperately that you have to replace before your next call, make sure you're notifying whatever supervisor you need to, so that you can get that done. Maybe go out of service just for, the 10 minutes or whatever it takes to get there, grab your things, and then get back on the road. Now that we've got everything, right, we've dropped our patient off, we've potentially restocked, we have to get back to the station. So inform dispatch whether you are in service or where you're going, right? Where I worked, like I said, we had hit the destination, put my mileage in. When I was back and ready to go on the road, we were ready to run calls. We would hit the available button, and we were good to go at that point. We would be available to tag whatever call is in our station, or in our area. Once we're back at the station, clean and disinfect the ambulance and equipment, restock supplies once again as needed. A big thing that we didn't talk about necessarily after the delivery phase is clean your gurney. Do a deep clean of it at the hospital. Most of them will have some sort of area where you can get ahead of that. So then that way, you don't have to spend time once you're back in the station deep cleaning stuff. You've got a good leg up on it, but it is a good point to keep. Okay. So post-run, we have completed our call. We have dispatched, picked our patient up, or gone en route, picked our patient up, transferred to the hospital, left the hospital. Now we're at our station. We are at the post-run phase. This is where now we get to do the fun stuff. We get to write charts, right? Everybody loves writing charts, but complete and file additional written reports. And then once again, we can inform dispatch of our location, status, availability. It really just depends on your system. Once again, the system I worked at, we had what's called AVL, so they could see where we were at all times. We were giving satellite information where our location was, so people were aware. Perform your routine inspections, refuel the vehicle, that's a big one. Depending on where you work, you may have different protocols for that. Where I worked, once we hit 3/4 tank, we needed to refill. Absolute worst case scenario is at half tank, but less than half tank, we are going out of service to get gas, because end of the day, if we run out of gas and we can't get somewhere, or my next call is a 2-hour drive and I have a 1/4 tank of gas, we're gonna have problems. Stay ahead of it so you don't have to worry about it as much when you're running calls. You can focus on what you need to focus on. So some key terms, make sure you're cleaning, disinfecting, right? Cleaning, disinfecting. We are not a sterile field, right? If you think about an OR, operating room, versus an ambulance. Ambulances are disinfected. We've killed as many of the buggies as we can. Sterile means there are none at all. They've deep cleaned, right? We don't have the capability because of the job we have. We use high-level disinfection and then sterilize as best you can. Deep clean, sterilize, disinfect, okay? Now, after each call, strip linens from the stretcher, place them in a plastic bag or designated receptacle. This typically falls under that when we're at the hospital, okay? Once again, depending. If you're someone who has to go back to your station to do this, that's tough. You may have to strip your linens and put them in a bag until you can get back to that place. Now, most ambulances will have backups of sheets, blankets, towels, pillows, as best you can. or depending on the station, okay? Discard medical waste, red bags will go into designated garbage cans, right? They're usually red biohazard bins. And then wash contaminated areas with soap and water. Now, when it comes to non-disposable equipment, we need to disinfect that, right? The monitor, for example, we take that into every patient or to every call. We need to make sure that monitor is clean so that we're not spreading germs. We don't want to be part of the problem. So clean the stretcher with germicidal or virucidal solution or 1 to 100 bleach dilution. And then clean spillage or other contamination with one of those same solutions. Depending on your protocols, they may have specific things they want you to do. We want you to use the gray tops for the gurney, the purple tops for the counters, right? I'm talking about the wipe canisters, if you know, you know. Okay, but keep that in mind. Different things will require different levels of cleaning. Even like bed bugs, we would use alcohol, spray alcohol, okay? So just be familiar with your protocols, but we do need to keep everything as clean as we possibly can. As far as defensive ambulance techniques, once again, ambulance wrecks happen more frequently than you would think, especially for such a high visibility, big, well-lit piece of equipment, but it does happen. Stuff happens. So an ambulance involved in a crash delays patient care and may take lives of EMTs, other motorists, or pedestrians. Car wrecks kill people, right? If you wear your seatbelt and you prep yourself well, most people turn out okay. Not to say they're uninjured, but okay. Okay, so just keep in mind, especially if we're in the ambulance and we get in a wreck, we have a slew of issues. I could be hurt as a provider. My patient, if there's one in the back, could be hurt. If I'm on the way to a call, it's going to delay that. So now a person's going to be waiting and we have to get another ambulance going. And that's assuming that the other motorists and pedestrians were not injured as well. So for driver characteristics, some states require an emergency vehicle operations course. EVOC is what we did here locally. And yeah, you learn how to drive the ambulance. You learn how to drive the ambulance at high speed and through an obstacle course. And it's pretty fun, frankly. It is kind of a good time. But it is something you got to be aware of, right? Be good at driving your ambulance. This is something that you need to be good at. You're paid money to drive. Be good at it. Okay, so other characteristics, physical fitness and alertness, emotional maturity and stability, right? We don't want anybody going off the handle, off the rails unnecessarily. And then due regard for the safety of others and preservation of property. It is your responsibility to do the best for everyone around you when you are in these pieces of equipment or on shift. Safe driving. So speed does not save lives, good care does. Studies are finding that going lights and sirens actually disrupts normal traffic and causes more accidents than just changing street lights, which a lot of ambulances have the capability to do. That said, right, sometimes we do gotta be fast, but being fast just to be fast is not a good enough reason. Be fast so that we can provide good care, controlled speed. Wear seatbelts, shoulder restraints, become familiar with how your vehicle accelerates, corners, sways, stops, right? You want to practice these turns, get familiar with it. And then always stay on the extreme left. We want to be as far left as we possibly can. We're constantly trying to push people to the right. That way we're clearing the road as best we can, creating a large alleyway for not only our ambulance, but whatever apparatus is following. Maybe a supervisor, maybe a fire engine, and that order can vary. Now, when it comes to the risk benefit analysis, I guess, of sirens, right? The decision to activate the emergency lights and siren will depend on local protocols, patient condition, and the anticipated clinical outcome of the patient. If there's someone who, let's making it up, they're having a stroke, time is brain. We need to be there as fast as we can so we can get them to a hospital as fast as we can. You might be using lights and sirens, but that's protocol dependent. That's depending on where you work. Okay, just remember, just because your lights and sirens are on does not mean that people necessarily see and hear you. New vehicles are pretty well insulated. They don't get road noise, so they don't hear sirens as well. And that's not even including the fact they could have their radio cranked up to 11, right? And they're gonna have a hard time hearing over that. Anticipation goes a long way. Right? Paying attention to the cars, not just the one in front of you, but 2, 3, 4 cars ahead of you as well. If a car 4 cars ahead of you is braking, likely that's going to affect you. Pay attention to it. Anticipate a little bit. That way it'll be a smoother ride, especially if we have someone in the back who, I don't know, maybe has got something like their a broken limb or a broken back or a broken whatever. And so going reckless and fast and brake checking them constantly is only going to be uncomfortable and potentially cause problems. So always assume that motorists around your vehicle have not heard your siren/public access system or seen you. Drive defensively. Don't be an offensive driver, right? We don't need to be trying to push people out of the way. We do need to be working our way to the left as quickly as we can get there safely. Okay, push people to the right as best we can, right? Motorists should be trained at this point to pull over for ambulances. But that said, anticipate that there are going to be people who aren't paying attention, who don't see or hear you. Okay, and that's only going to get in the way and could risk, your safety as well. So the cushion of safety, so maintain a safe following distance from the vehicles in front of you. Okay, typically the 3-1,000 count works well. Try to avoid being tailgated from behind. I mean, that's easier said than done, especially if you have maybe somebody following you in their personal vehicle for maybe a loved one on the ambulance. They tend to try and catch every single light and speed up just to be right behind you. Make sure you preface and tell them, we don't need you to go fast. We need you to get there safely. We will go fast. Okay. Ensure that blind spots do not prevent you from seeing vehicles or pedestrians. So be familiar with your ambulance blind spots or your engine blind spots. A big one is that front driver post attached to your windshield there. That one gets in the way and can block pedestrians if you're not careful. Never get out of the ambulance to confront a driver. You're at work, be professional, right? You are held to a higher standard and the optics on you are constant. You're not only representing yourself, you're representing an agency, maybe even a government agency, okay? It's not our job to get out of the car and start fighting people. I would heavily advise to avoid that. And then be aware of blind spots and scan mirrors frequently. Also remember, if we have a box on the back, we're in an ambulance, right? That middle mirror doesn't do a whole lot for us. We're only looking straight into the back. So get really familiar with your left and right driver mirrors, okay? A lot of them nowadays will have some sort of blind spot mirror as well, but be familiar with the limitations of your vehicle, be familiar with your limitations and what you need to do to overcome them. Excessive speed, so unnecessary, dangerous, and does not increase the patient's chance of survival. Just because we're driving fast doesn't necessarily we're doing the best thing for our patient, especially if we're driving half recklessly, trying to go super, super fast, and then we run the risk of causing more traffic collisions, more traffic accidents, disrupting light cycles, things like that, okay? Saving one person but causing 9 other people to get in trouble or to harm themselves or be harmed on the way to the hospital does us no good and only affects the reputation of your agency. Okay, so hinders the driver's reaction time as well. Makes it difficult to provide care in the patient compartment. If you talk to anybody who's had their sea legs or been on an ambulance for a while, they'll tell you the amount of times they've been thrown into the wall or into the gurney or into the bench seat. Okay, which another thing, wear your seatbelts in the back. Nowadays they make harnesses that you can stand up and still operate with, okay? But yeah, it gets in the way of patient care. If you're taking corners, 80 miles an hour and I'm standing up, you're gonna throw me forward and then I can't help my patient if I can't stand up or sit or be comfortable while providing care. And then increases the time and distance needed to stop the ambulance. The faster we go, the longer it takes to slow down, okay? So keep that in mind. This is where being anticipatory and planning goes a long way while you're driving. Hold on to being a defensive driver. Siren syndrome, not very real. Causes drivers to drive faster in the presence of a siren due to increased anxiety. When we think of lights and sirens in this country, a lot of times we think of police, right? And the police light up behind you, anxiety immediately. So if we're driving down the road and we just see red and white lights flashing, that could be a concern to us, right, as drivers. And some people will speed up. Not everybody's got the sense to get over out of the way. Keep that in mind, especially if you're going to be working somewhere that has a heavy refugee population. They may not be familiar or as familiar with the traffic laws or with emergency vehicle kind of function, right? So the road laws around that. So keep in mind that once again, being defensive goes a long way. Just because you're a defensive driver does not make you a bad driver, okay? And then vehicle size and distance judgment. So crashes often occur when the vehicle is backing up. So always use a spotter. That was policy where I worked. If you're going to back the ambulance up, always needed to get someone to get out, back you up, tell you lefts or rights, right? Making sure that you're going the right direction. And then size and weight influence braking, once again, stopping distances. If you're going fast, right, you got to understand how these vehicles will maneuver. So road positioning and cornering is important. To keep the ambulance in the proper lane when turning, enter high in the lane, exit low. So entering high, right? And then we're going to hit that apex late. Another way that I used to teach when I was out there and I had, like a student or a newer person, we can light up the straightaways. We can go fast on the straightaways. When we get to corners, take the corners slower, because remember, you have people standing in the back. You have a patient who's potentially injured. So if we go swinging those corners really fast, we run the risk of causing more problems, okay? Take your turn, and then you can always hit the straightaways. And then keep in mind, weather and road conditions. It does make a difference. Depending on the time of year, people are going to drive differently, right? Winter, somewhere where it snows and ice is over, versus summer is going to be very different. The road laws change a little bit. Your braking and your acceleration changes, right? So ambulances have a longer braking time and stopping distance. If the weight of the ambulance is unevenly distributed, it makes it more prone to roll over, right? If one side's far heavier than the other, and we're taking turns incredibly fast, we could tip ambulances. It does happen. Not often, but it does. But if it's high water content, hydroplaning, very, very real. Water on the roadway, decreased visibility, ice, slippery surfaces, all of them are potential risks for not only our safety, but bystander safety as well. Because remember, if we're causing more accidents, we're not doing a whole heck of a lot of good. Now, as far as laws and regulations go, this is going to be kind of specific to where you lived, specific to your department. If you're on an emergency call and you're using your warning lights and sirens, you may be allowed to do some of the following. Park or stand in an illegal location, right? How many people get out and walk across the freeway? Proceed through red lights or stop signs, depending on where you work, right? You might have to stop at the red light, clear the traffic, and then go, but you can still go through them, right? We can drive faster than the speed limit. Where I work, we could go capped 15 miles an hour over the speed limit, except for when we hit the freeway where we are governed at 80. Okay, so you will be going faster than the average traffic. Drive against the flow of traffic. Yeah, from time to time, I would go into the oncoming lane as long as it was cleared and I was notifying, right, where I should be going. And then travel left of center to make an illegal pass. From time to time, you have to. You might have to pass somebody around on the left side instead on the right if it's a 2-lane road. It's 100% for, the person driving is not paying attention for one reason or another. Because sometimes you'll see them do this kind of panic stop where you'll see them swivel when they see you behind you and then they slam on their brakes. If you got to get around them, you got to get around them. An emergency vehicle is, however, never allowed to pass a school bus that has stopped to load or unload children. Same with school zones. You must operate within the school zone following school zone laws, which let me tell you, you'll never feel dumber than operating a light and siren going 20 miles an hour in a school zone. So maybe turn the sirens off, okay? For that moment, once you're back to moving fast, you can always turn them back on. The unit must be on an emergency call, though, if we're going to use lights and sirens. Audible and visual warning devices must be used simultaneously, and the unit must be operated with regard for others' safety. Due regard, we're always operating in the best interest of the public around us, even when we're just driving a vehicle. Right-of-way privileges. Emergency vehicles have the right to disregard the rules of the road when responding to an emergency. Just because you're up to turn left does not mean that I can't pass through that intersection. Okay, that's going to be kind of a mutual respect thing. You need to make sure, as me driving the ambulance, being defensive, slowing down, that way I'm not just causing more collisions. But then by extension, the lay person driving their vehicle needs to be aware emergency vehicles can also breach road laws. Okay, do not endanger people or property under any circumstances, and then get to know your local right-of-way privileges. All depends, once again, on the systems you work for. Escorts. Use escorts as a guide only when you are in unfamiliar territory. Depending on where you work, you might have a set district. If you have a set district, you'll be working for a good period of time. Get familiar with it, right? But sometimes we may need, hey, I don't know where I'm going. Can you show me what the route is? Rely on the people who can give you help if you need to. Intersection hazards. Intersection crashes are most common and the most serious, right? So vehicles coming across, either head-ons or T-bone type collisions. Keep that in mind, right? End of the day, we're trying to avoid all collisions generally, but intersections in general can be dangerous. So for us, we had to stop at the stoplight out of red. We could always run it if we had the lights and sirens, but I would do that to clear these intersections, make sure I could go through safely. If you cannot wait for traffic lights to change, come to a brief stop, look for pedestrians or other hazards. Once again, department dependent. Highways, shut down emergency lights and sirens until you've reached the far left lane. Get over and be prepared, right? So we can set ourselves up for success. That way people aren't going to be kind of wondering what you're doing and where you're going. Also, depending on where you work, most vehicles will outrun the sound of the sirens at around 65 miles an hour. So depending on where you work, you may have protocols for that. But unpaved roads operate at a lower speed with firm grip on the steering wheel. We don't need to be going super fast through a mountain gravelly road, right? That's how you get runoffs. That's how you get some sort of accident occurring because of the road condition. Go slow. And then school zone, always unlawful, like I said, to exceed the speed limit. When you are driving, distracted driving is a problem. A lot of agencies I've seen or heard of people doing one-handed driving, one hand on the wheel, one on the siren. Depending on your agency, that can look different. For the most part, they are making more hands-free sirens to swap through. It's just hitting the horn. Utilize that to the best of your advantage, especially when you're new and you're easily distractible just because you don't know where everything is to the same degree. But minimize distractions. Mobile dispatch terminals and GPS, mounted mobile radios, stereo, cell phone, eating, drinking, try to avoid them as best you can, especially driving code. If you're driving emergent 911 code, right, light sirens, you gotta be safe, you gotta be paying attention because it's not only your life, not only your patient or your partner's life in your hands, it's everyone around you if you're making bad decisions. When driving alone, it is your responsibility to focus on figuring out the safest route while mentally preparing for the call. Okay, figure out where we need to go, what do we need to do to be prepped, but make sure that you are responsible for it. Because understand, at the end of the day, it comes down to you. Are we going to get to where we need to be because you took the right turn or not? And then such situations, once again, demand complete attention and focus. Try to avoid being distracted on that one. Okay. Fatigue. Recognize when you are fatigued and alert your partner or supervisor. This is a field where people get tired. A lot of us work 24-hour shifts. Okay. It can be dangerous. I saw a study that was saying that sleep deprivation can actually basically mimic a blood alcohol of a 0.08, okay? Maybe even higher. So be alert and be aware of it. Sometimes you can't avoid it. You gotta do what you gotta do to stay awake. But if you're getting so tired, you're having a hard time driving, you're so fatigued, you're having a hard time driving, notify your partner, notify a supervisor, do what you gotta do. You should be placed out of service for the remainder of shift or until the fatigue is passed and you feel capable of operating the vehicle safely. I'm going to leave that to whatever department you work for and your protocols because realistically, that's going to differ depending on where you live. For air medical operations, right? So air ambulances, helicopters, fixed wings being airplanes, but helicopters also known as rotors or rotary wings. Anyway, air ambulances are used to evacuate medical and trauma patients, right? So this is going to be more of our more rural kind of back area type situations. And you will have to call for them. Now, a specially trained crew accompanies air ambulance flights. So EMTs provide ground support, flight paramedics, critical care paramedics, critical care nurses, flight nurses, they will be on the air medical apparatus. Okay, so medical evacuation, medevac, is performed by helicopters, and their capabilities, protocols, and procedures are gonna vary depending on where they're at, what they're used for. Is this gonna be like a wildland firefighter or fire evac, or is this gonna be a life flight evac? It's gonna look a little different. Now, why call for medevac? Transport time by ground's too long. We have an hour-and-a-half drive ahead of us to get to the closest hospital going lights and sirens. A helicopter could potentially get in and out in an hour, 40 minutes. So it saves us time, it gives the patient a better chance of a good outcome. If road, traffic, or environmental conditions prohibit the use of ground transport. Now, I'll also tell you, the weather conditions are going to get in the way of being able to fly a helicopter, right? So there are things where sometimes we have to drive and it's going to be slow and a lot of patient management. If the patient requires advanced care quicker, adding that, right? Multiple patients will overwhelm the resources at the hospital, reachable by ground. Sometimes we have 5, 6 patients and we'll send the 2 most critical, get other ground ambulances out. Who receives medevac? Patients with time-dependent injuries or illnesses, patients with strokes, heart attacks, or spinal cord injuries as examples, scuba diving accidents, near drowning, skiing, wilderness accidents, trauma patients, candidates for limb replantation, burn centers, hyperbaric chambers, or venomous bite centers, someone who needs care quickly, okay? Who do we call? You're gonna tell the dispatcher first. Hey, we need to launch a helicopter. Okay, you may even hear, we need to launch a bird, right? Same thing, you need a helicopter. But in some regions, EMS may be able to communicate with flight crew after initiating the medevac request. Where I worked, we could hail them ourselves with a state comms radio as needed, but we would still notify dispatch. Establish a landing zone, so hard or grassy level surface between 60 by 60 and 100 by 100 feet, with 100 by 100 feet being the most recommended landing zone area. Cleared of all loose debris, clear of overhead or tail hazards, right? So we don't want power lines or tilted mountains. Mark the landing sites using cones or vehicles, maybe even flares at night. Never use caution tape or people, don't use flares, just kidding. Never use caution tape or people to mark the site, and don't use flares. Now I'm thinking about it, flares could be 1, distracting light, but 2, you just never know, right? If we're gonna be landing someone in maybe a dry, brushy area, fire risk. Move non-essential persons and vehicles out of the way of the landing zone, and then communicate the direction of strong wind to the flight crew if you have access. Landing zone safety and patient transfer. So keep a safe distance from the aircraft whenever it is on the ground and hot being on with that rotor moving, right? So stay away from the rotor if it's moving. These people are trained, the flight crews are trained to be around those rotors, right? We necessarily are not, so, or are not necessarily. So keep that in mind, but stay away from the tail rotor, stay away from the overhead rotor as best you can. And when we approach a helicopter, it's always from the front, never from the rear. Those rotors are moving so fast, you can't necessarily tell how long they are. So keep yourself safe and just avoid them. Yeah, so here you go. Approach crouched. We don't want to be towards that tail rotor at all. Okay, and the main rotor blades can dip as low as 4 feet off the ground. So situationally, pay attention. Keep the following guidelines. So become familiar with hand signals. Do not approach the helicopter unless instructed and accompanied by a flight crew. Make certain that all equipment and the patient are secured to the stretcher. Smoking, open lights or flames or flared are prohibited within 50 feet. And then wear eye pro. Wear eye protection because when that helicopter's landing, it's pushing debris, dust, rocks, dirt, whatever you want to call it, fast, and it can hit you in the face. So protect yourself. We want to avoid our eyes being involved. All right, and so here's some of our hand signals for those of you who are wondering. So some special considerations. Night landings. Do not shine spotlights, flashlights, or any other lights in the air to help the pilot. Direct low intensity headlights or lanterns towards the ground so they can illuminate the ground. And then illuminate overhead hazards or obstructions if possible, if needed, right? If we are going to be setting up a good landing zone, we should be away from those anyway. Landing on uneven ground, the main rotor blade will be closer to the ground on the uphill side, so approach from the downhill side, right? If hill's there, or this is kind of a tilted one, but if this was landing straighter, this rotor would be kind of closer to the ground there, so we want to avoid that. So go towards or approach from the downhill side, that way we can keep that overhead clearance. Medevac for hazmat incidents. Notify the flight crew. Consult about the best approach and distance from the scene. Landing zone should be uphill and upwind, right? Trying to avoid any contaminant getting back. And then decontaminate patient before loading him in the helicopter. Last thing we want to do is if someone's covered in, I don't know, pepper spray, for example, and we put them in that helicopter, now it's affecting everybody's face and eyes, and that includes the pilot. Okay, so decon off as best you can. Keep them as protected as you can. So for issues of medevac. Assess the severity of the weather or environment/terrain. Now, most helicopters are limited to flying below 10,000 feet above sea level, so depending on the travel distance, right? And then helicopters will fly anywhere between 130 to 150. Now, because the cabin's confined space, assess the number and size of the patients who can be safely transported by medevac. Flight crews have a very specific standard of height and weight that they have to be so that the aircraft is not thrown off. Okay, so make sure you're notifying them, hey, this is a larger person, XYZ, right? And then typical medevac flights are extremely expensive compared to ambulance transports. It's true, right? Bigger piece of equipment that requires more specialized personnel is going to be more expensive to deal with. Okay, so that is our transport operations lecture. If you have any questions, as always, feel free to write one in the comments, like, subscribe, and we'll see you next time.